Welcome to the Cleveland Clinic South Pointe Orthopedic Surgical Residency educational video series. This series was created for educational purposes designed to aid in patient care and teaching proper steps and techniques for commonly completed bedside orthopedic skills and procedures. In this video, we will provide a demonstration on the proper technique for completing a hematoma block, ankle fracture reduction, and application of a well-molded short leg posterior splint with stirrups. Begin by identifying relevant anatomy, including the tibialis anterior tendon, medial malleolus, and joint line. We've additionally drawn out the medial malleolus and tibialis anterior on this mannequin as shown. It is important to avoid going lateral to the tibialis anterior so as to avoid any neurovascular injury. Provisionally mark the desired entry point and gauge the appropriate angle. Sterilely prep the ankle and prepare to perform your hematoma block. Generally, 10 cc's of anesthetic is sufficient and should be drawn into a syringe. Attach an 18-gauge needle. This profile view again nicely demonstrates the relevant anatomy to guide you when entering the ankle. Inject your anesthetic while occasionally barbitaging the fluid. This barbitaging, or aspiration of fluid, allows you to confirm that you are in hematoma and in the correct location. Another important point to keep in mind while aspirating or injecting the ankle is to hold the ankle to ensure that it does not move. After completing your hematoma block, begin preparing your splinting material. You will want to measure the appropriate length for both plaster components. In the acute fracture setting, the contralateral leg is beneficial for this. Next, you will roll out your plaster sheets for both the posterior slab and the stirrup. You should shoot for at least 10 plaster sheets for both of these, and in most cases, when holding a reduction, we recommend 15. Ensure that you make these an appropriate length and that you do this in an overlapping fashion so as to make it easier to hold onto these when you dip them in the water. You are now ready to begin wrapping the leg. By now, a reduction maneuver has been completed, and the assistant's job in holding the leg is critical to maintaining reduction. The stockinette should be cut longer than necessary. It is important to note that the resulting supination, adduction, reduction, and holding technique, or the Quigley maneuver, is the most common maneuver, but not the only for ankle fracture reduction. For further elaboration on less common reduction maneuvers encompassing all types of ankle fractures, please reference our coinciding PowerPoint slideshow on ankle fractures. It is also important to note here that prior to a final reduction attempt, in the acute setting, a preliminary reduction can be used to alleviate areas of skin tenting, so as to avoid soft tissue compromise or an open injury at a later time. Begin wrapping the ankle with a 1/2 overlap of the synthetic roll or web roll. Ensure all wrinkles are removed. You do not want to underpad the splint, causing skin issues, but you also want to avoid overpadding the splint for risk of losing reduction. Throughout this process, the assistant is holding the knee at 90 degrees of flexion, which is critical, while also using the excess stockinette to maintain reduction with a Quigley maneuver, directed towards the patient's contralateral shoulder. Enough of extra padding is created at the proximal portion to again prevent any future skin issues. The most important area to ensure is adequately padded is the heel. A separate slab of synthetic roll, or rest-on if available, should be utilized here. The most distal extent of the padding and splint should still allow for the toes to remain free. This should not extend past the MTP heads. Once placed, a final singular layer of padding is added and the plaster is prepared. Again, any padding beyond this will create a chance for losing reduction. The plaster should be dipped in warm water. Do not let go of either end of the plaster at this point, as it still can come undone. Remove excess water from the plaster by wringing it out and patting it dry on a towel. Be cautious of being overly aggressive with either of these steps, so as to not remove all of the plaster from the sheets. You do not want to apply a sopping wet splint, but you also do not want to lose reduction. Begin by applying the posterior slab. You may fold over excess plaster, but attempt to limit this to just the ends. Utilize a light and quick wrap of synthetic roll to hold this in place while your assistant stabilizes. Continue to avoid any wrinkles in the plaster throughout the wrapping process. And once this is completed and secured, you can move on to applying your stirrups. Repeat the process as before and place your stirrups. When placing the stirrups, ensure that they are placed overlying the medial and lateral malleoli. You do not want these resting too anterior or posterior on the ankle. Your assistant should continue to hold their position, and at this point, you should apply a final wrap to the plaster to avoid placing an ace directly to the plaster. Ensure any edges are folded down. The knees should be able to bend with the splint in place without any plaster digging into the sides of the knee or into the popliteal fossa. A provisional ace wrap should be applied to hold the dressing in place as a mold is applied. When beginning to mold, hand positioning and the pressure applied are everything. This takes a significant amount of force and should be held until the plaster has completely hardened. With the ankle dorsiflexed against the chest and your assistant providing counterpressure at the knee, begin holding the mold. Technical points include applying pressure with the flat surfaces of the hand, as well as squeezing primarily medial lateral. There is a slight anterior-posterior vector as well, and the hand medial should lie slightly anterior, while the lateral hand should be positioned slightly posterior. The lateral hand can aid reduction with a slight cupping of the heel as well, depending on the fracture pattern. This again should always be held until the plaster has completely hardened. At this point, you can cut the excess stockinette, fold down the ends, and apply the final ace wraps. At this point, you should always obtain final post-reduction or post-splint application x-rays. And lastly, this is again the most common reduction and splint application. But for more information on other ankle fracture types and how they may be treated, please view our PowerPoint. Once this is completed, it is always of benefit to elevate the patient's leg as much as possible, whether that be with a cast elevator, blanket stack, or pillows. We thank you for viewing this segment of the South Pointe Orthopedic Surgery Residency Educational Series. We hope this video was beneficial and that you will utilize other videos from our series, as well as the correlating PowerPoint slideshows that expand upon each of the respective topics.